Hello, my name is Kendall Robinson, and this is my master's project on gouty arthritis. I chose to do my master's project on this topic because I find rheumatology to be very interesting as a whole, and then specifically, I really like gout because of the variety of both acute and chronic treatment options for this condition. During this presentation, I will discuss the general features, clinical assessment, diagnosis, treatment, and patient education as it pertains to gout. Let's get started. So, general features. Gout is an inflammatory arthritic disease affecting the joints. The disease is characterized by acute gout flares that present as a sudden, extremely painful red joint. The first metatarsal phalangeal joint, or the big toe, is most commonly affected. In patients with gouty arthritis, elevated serum uric acid levels cause urate crystals to be deposited within the joint space. These crystals cause damage in the joint space, leading to an acute flare, and that causes the pain, inflammation, and redness that we commonly see in these patients. Chronic uncontrolled gout may present as persistent joint pain, stiffness, and diminished range of motion. Risk factors for gout include male sex, advanced age, low estrogen states, particularly those found in postmenopausal women, as we do know that estrogen is protective against gout. Additionally, consumption of foods high in purines, such as alcohol and red meat, is another risk factor, as well as kidney disease and certain medications, including some thiazides and certain tuberculosis medications. Clinical assessment. Common physical exam findings in patients experiencing an acute gout flare include a swollen, red, and extremely painful joint. These findings are typically monoarticular, meaning that they affect one joint, and are commonly observed at the big toe, as previously mentioned. The patient may appear distressed due to the severity of the pain and may not be able to tolerate anything touching the joint, such as socks or shoes or even the bed sheet. Serological evidence of gout includes elevated serum uric acid levels. However, it is important to remember that serum uric acid levels may be within normal limits during an acute gout attack, as these urate crystals are no longer in the serum but have been deposited within the joint space. It is also important to note that some patients may have hyperuricemia on labs but may show no symptoms. Joint erosion and tophi formation within the joint space are common findings on plain radiographs. Additionally, on x-ray, patients that have lesions characteristic of gout, often these lesions are described as punched out with overhanging edges. The gold standard method of diagnosis for gout is an atherocentesis with synovial fluid analysis. The analysis will show needle-shaped, negatively bifringent monosodium urate crystals, and these results are pathognomonic for gout. Though a definitive diagnosis is made by the presence of these uric acid crystals within the synovial fluid, gout can also be diagnosed based on other aspects of the patient presentation. For example, a patient presenting with elevated serum uric acid levels in addition to previous signs and symptoms of gout can be diagnosed and appropriately treated at that time. In gout patients, serum uric acid levels typically exceed 6.8 milliliters per deciliter, and you may also see elevated acute inflammatory markers, including ESR and CRP. The differential diagnosis for a patient with suspected gout includes rheumatoid arthritis, osteoarthritis, septic arthritis, psoriatic arthritis, cellulitis, and pseudogout. When treating gout, the two goals of medical management are to alleviate the pain and lower serum uric acid levels in order to prevent acute gout flares. Therefore, the treatment of gout can be broken up into acute and chronic categories. For our acute treatment options, NSAIDs, steroids, and colchicine are all commonly used in the acute setting. NSAIDs, such as indomethacin, are considered first line of treatment in the acute setting and work by decreasing the production of prostaglandins in order to decrease pain. NSAIDs should be avoided in patients with kidney disease, cardiovascular disease, and active GI disease. Steroids are an appropriate acute treatment alternative in patients with contraindications to NSAIDs, particularly those with chronic kidney disease. However, it is important to remember that steroids should be avoided in patients with diabetes as it may cause a disruption in their glycemic control. Finally, colchicine is a unique medication because it is indicated for both acute and chronic gout treatment. This medication is most effective if administered within 36 hours of the attack onset, and it is important to warn your patients that diarrhea is a common side effect of this medication, but it should improve with time. Chronic gout treatment involves an array of urate-lowering medications. The goal of chronic medical management is to maintain healthy serum uric acid levels. And typically, the goal is to have those uric acid levels less than 6.0. Allopurinol is considered the first line of treatment in the chronic management of gout. This medication is a xanthine oxidase inhibitor that works by decreasing the production of uric acid. Probenecid is an adjunct medication that promotes urinary excretion of uric acid. So it's maintaining lower uric acid levels by excreting it through the kidneys and into the urine. This medication should be avoided in patients with decreased kidney function as it's going to negatively impact the efficacy of this medication. Pegloticase is another adjunct medication that is typically reserved for severe and refractory cases of gout, such as patients with evidence of tophi on X-ray or those with frequent and uncontrolled gout flares. Patient education. It is important to educate patients on the lifestyle modifications they should implement to maintain control of their disease. Patients should avoid excessive consumption of alcohol, red meat, and other foods that are rich in purines. Additionally, weight loss should be encouraged as it helps to reduce the physical stress on all of the joints. It is important that patients are compliant with their treatment regimen. The key to preventing acute gout attacks is to maintain a healthy serum urate level. This is best achieved when patients take their medications as prescribed. If untreated, chronic hyperuricemia can contribute to a higher morbidity rate and may lead to severe debilitation, which will or has the potential to severely impact the patient's quality of life. That concludes my presentation. Here's a list of references that I used to put together this presentation. Thank you for your time, and please let me know if you have any questions.